Hello all, welcome back to Legal Medicine channel. So today I'll be talking on the topic called Sprengel Shoulder, and this Sprengel Shoulder is an important 4 marker in final MBBS part 2 orthopedics question paper. So I'm going to deal this topic in an exam oriented way only. Okay, so Sprengel Shoulder is a rare congenital anomaly. Normally, if you look at the embryological aspect of the scapula rides from an higher point, that is from the cervical level to the thoracic level. It comes from cervical level to the thoracic level. So this is called the caudal migration. So any interruption in this caudal migration characterized by high riding or highly elevated scapula which is medially rotated will lead to a condition called Sprengel shoulder. To keep it very short, normally this scapula has to come from higher point to lower point, and any interruption in this journey will lead to the scapula that is usually placed at an higher level than the normal level. So this higher place scapula or high riding scapula, which is medially rotated along with the presence of another bone that is called omovertebral bone, will give me the clue and will tell me that this condition is a Sprengel shoulder. I'll be talking about the omovertebral bone in the later part of this video. So till now you just have to remember this, and this is common and it's equal in both sexes, and left side is more common than right side. And if you can see the x-ray, the right side depicts the normal scapula which is lying at the level of T3 or some other level, a normal position, whereas the left side shows me that the same scapula is placed a little higher than the right side scapula. So this highly placed scapula or high riding scapula on the left side which is medially rotated, will give me a clue that it is a Sprengel shoulder. And like I've told you, normally at the level at the 5th week, the scapula usually lies at the level of C4 to C6. By the time of 12th week, this is the embryology that I'm talking about. By the time of 12th week, the scapula comes to the level of T3 or it goes a little below T3, and that is the normal position of the scapula. So any interruption in this caudal migration is called Sprengel scapula or Sprengel shoulder. And this interruption usually occurs between 9th to 12th week of the embryogenesis or embryology. Okay. And coming to the pathophysiology, normally whenever the scapula is placed at certain point, there are some muscles associated with scapula. Okay, so these muscles are placed at an abnormal point. So what we tend to normally write is that these muscles that are in and around the scapula are usually hypoplastic, or they're usually absent because the scapula is present at an abnormal location, or highly placed scapula. That is what we can write. So that is what we'll tend to know. So trapezius, rhomboid, levator scapulae may be absent or hypoplastic. And there is something called serratus anterior, and serratus anterior is usually weak, leading to winging of scapula. Based on our first year anatomy knowledge, we can write winging of scapula. And pectoralis major, latissimus dorsi, and sternocleidomastoid may be hypoplastic because of its abnormal location. Simple. Then coming to scapula. If you look at the scapula is dysplastic. What do you mean by dysplastic? Dysplastic means abnormal in size and shape. Normally, scapula, you all know how scapula looks, right? So if you look at this scapula, Sprengel scapula, horizontally this Sprengel scapula is larger and vertically it is smaller and also medially rotated. Okay, so this is called a dysplastic scapula. Also, because the scapula is lying at an abnormally high position, the distance between the clavicle and the scapula is narrowed. So the scapuloclavicular space is usually narrow, or there is some space, but very rarely you tend to see that. Okay, but the space is narrowed. This is what you'll have to write in your exam, and certain anomalies are seen along with this condition, like spina bifida, scoliosis, klippel heel anomaly, hemivertebrae, and when we talk about the rib abnormality, cervical ribs, fused ribs, this is what we tend to see. Okay, some anomalies associated with this condition. You can write it or you can just omit it also. It's up to you. And coming to the omovertebral bone, I told you, right? Normally, the high riding scapula, which is medially rotated, and along with another bone called omovertebral bone, tells me that this condition is a Sprengel shoulder. So what exactly is omovertebral bone? Omovertebral bone, like you can see here, it is a small It is a small trapezoid or rhomboid shaped bone that usually extends between C4 to C7 part of the vertebra, and it is usually present at the level of the superior border of the scapula, and it attaches to any part of the spine. So this is the omovertebral bone. Usually it is not present in normal people, but in these conditions omovertebral bone can be seen. So omovertebral bone and its presence will surely tell me that this condition might be a Sprengel scapula or Sprengel shoulder. Okay, I hope it is very clear till now. And coming to the clinical points. So what clinical features do you see? So we will broadly classify this into two things, that is cosmetic and functional. So when we talk about the cosmetic thing, usually the scapula is highly placed, and because of highly placed scapula we tend to observe scoliosis, torticollis, and if the scapula is very much high, then we can even find caput obsteosum, and also facial asymmetry because of its highly placed scapula along with torticollis and all. Facial symmetry will also be lost, so facial asymmetry is usually seen. Coming to the functional aspect, normally the movements are restricted. Movements of scapula and shoulder joint both are restricted, and greater than 90% abduction is not possible. Okay, and when we talk about the Cavendish staging, so normally we stage this particular condition into four stages, that is grade 1, grade 2, grade 3, grade 4, which is very mild, moderate, severe. Okay, so if you take grade 1 or very mild condition, the shoulder level is normal. When we compare it with the opposite side, or the normal shoulder, the shoulder levels are usually normal, and no deformity is seen when the person is dressed. Okay, when the person is dressed or when the person wears a shirt or something, if you look at the scapula from behind, you cannot find any deformity, and the shoulders are at the same level. So we can grade this into a very mild condition. And grade 2 is mild. The shoulders are almost at the same level, not at the same level, almost at the same level, and a small lump is seen when the person is dressed. Okay, grade 3 is moderate, slightly elevated from almost at the level to slightly elevated, and the deformity is visible. Then coming to severe, highly elevated scapula, and this is usually seen superior angle at the occiput. This is usually seen at the superior angle at the occiput. Okay, superior angle is actually seen at the level of occiput. Okay, and coming to the diagnosis, X-ray is the gold standard for this. I've shown you the X-ray picture also. So X-ray is the gold standard for this particular condition. What we tend to see, like I've told you, elevated scapula, omovertebral bone, medially rotated scapula, and dysplastic scapula. And CTs can also be done. Prognosis is not favorable even if it is operated. Normally it is favorable, but not up to the mark. It doesn't come, even if you operate, the person's functional level doesn't come up to the mark. So it is not usually favorable, but okay, we will have to do the surgery, so we will do it. But the patient doesn't have the 100% satisfaction. Okay. Coming to the surgical treatment, the best age for the person to undergo surgery is 3 to 8 years of age, and we will usually consider moderate to severe deformity. And also normally, if you want to write it very briefly, okay, normally what happens is, because the scapula is at the higher level and the associated muscles around the scapula, in and near the scapula, are usually they are usually present there. So for us to bring the scapula from the higher point to the normal point, for us to bring the scapula caudally, so we'll have to cut down these muscles that are actually supporting the scapula, right? So what we usually do is we remove the origin and insertion of these muscles. After removing the origin and insertion of these muscles, the omovertebral bone that was at the level of the superior border of the scapula will also be removed, and clavicular morselization will be done. You will just have to remember till the year, and for this there are some procedures. You just have to write these procedure names, and that is more than enough. If you can write this, you will be given 4 out of 4. Okay, so the procedures are Putty's procedure, and for a better understanding, I'll take it as shock modified Putty's procedure. So first thing is Putty's procedure, and then comes the shock modified Putty's procedure. Then comes the green scapuloplasty, then modified green procedure, then comes the Woodward procedure and Mears procedure. And if you can write till here, I'm pretty sure you'll be given 4 out of 4. And that's all about Sprengel scapula.